Good afternoon, everybody. Thanks for that, Rick. I'm George Leibowitz. I feel very privileged to be part of the Tele-Psychiatry segment of today. I'm actually a professor in School of Social Welfare, and coming from the, as Mary pointed out, coming from the University of Vermont. I work currently as our local PI on a PCORI grant looking at it's a randomized control trial looking at whether or not co-located clinicians, behavioral health clinicians, work less well than an integrated care model, and we have a lot of discussion about the benefits and we have a lot of proponents of integrated behavioral health, but we really want to know, what does it look like on the ground? Is it in fact better in terms of patient outcomes? So that's an ongoing trial. Stony Brook Medicine is involved in that project. Today, we'll be talking a bit, briefly carrying on this conversation of telehealth and telemedicine, specifically addressing what has come up several times today around the opioid use disorder issue for us in the epidemic, and through an integrated behavioral health workforce lens. Does, in fact, behavioral health training our workforce make a difference and increase access through care through models that specifically address the opioid addiction problem through telehealth? So everybody knows this is a slide that essentially talks about the sort of burden of opioid-related mortality and overdose deaths in the United States, that we know that premature death from opioid-related causes imposes an enormous public health burden across the United States, and the recent increase in deaths attributable to opioids highlights the needs for targeted programs and policies that focus on improving addiction care. You can sort of see, if you sort of look at this slide, which is a few years older now, that between 1999 and 2014, we saw a fourfold increase across this time, and that the drug overdose rate surpasses traffic accident rates. In 2015, we saw about 52,000 deaths. 33 of those were implicated in opioids. More recently, in 2016, the number of opioid-related deaths in the United States increased by 345% to over 42,000 deaths, and specifically that was attributed to ODs. Rick mentioned and others mentioned HRSA, which the Health Resource Services Administration has been, of course, putting a lot of oomph, if you will, behind telehealth for a number of years. In 1998, HRSA's first telehealth program was launched as the Office of Rural Health Policy, and in 1992, 4 years later, the Office of Advancement for Telehealth was instilled, supporting projects across the U.S., now with about $23 million behind it, and including things like internet-based assisted treatment from patient to provider, video conferencing, the store and forward thing that Rick mentioned earlier, as well as diagnostic images and streaming media. So this is a copy of their website. It's worth going to this website and paying attention to what HRSA is doing. And due to the passage of the Opioid Response Act recently in 2018, we saw a lot of funding mechanisms that are going to be released specifically to use telehealth to address the opioid crisis. So we also heard a lot about hub and spoke today for opioid addiction, and I won't belabor the point about hub and spoke. Suffice it to say that the notion of establishing regional specialty centers responsible for the coordination of care for individuals with opioid use disorders and other co-occurring conditions is very important. There's a lot of evidence behind it, and that using medication-assisted therapies has been shown to be an effective treatment, specifically for opioid addiction, that involves prescribing antagonists or agonists, methadone or buprenorphine, in combination with counseling that has been shown to be effective. I think the slide we deleted, but it wound up back in. So that basically says what methadone and buprenorphine are blockers and occupy the opioid receptors. We won't get into a neuroscience talk here, but let's move on. So what does it mean to talk about an integrated health system for addictions treatment. The hub and University of Vermont and John Brooklyn, specifically a psychiatrist in Vermont, recently, if you get a chance, just Google his name. There's a lot of publications with evidence behind Vermont being listed as a hub and spoke model for the country in a lot of ways, and this is expanding. And the program essentially enhances the provision of MAT, care coordination, and complex addiction consultation by adding new healthcare staff to both hub-designated providers and the spokes that provide, for example, spokes to the health home services, for example. The spokes include mental health clinicians, pain management folks, outpatient addictions, and by the way, I don't know how often this has come up today and around telehealth. Let's not forget corrections and correctional facilities and jails, which occupy a significant patient population for us, and that's also part of hub and spoke. The main goal, essentially, of hub and spoke, insofar as it applies to health system for addictions treatment, is to prevent overdose and deal with the opioid crisis. And each region having the specialized addiction center of expertise is connected, for example, to all the waivered buprenorphine doctors as part of the spokes, and there's a dedicated clinician in each of these sites. So the hubs essentially serve as referral for the spokes, and with providing on-site counseling to address mental health issues, medical issues, and particularly chronic pain management in this case, which is very important to us. Okay. Oh, am I running out of time already? So let me move. I think these got reversed. This is the old one, right? So this is out of order to where I wanted to go. But Project Echo. Actually, I'm going to skip ahead where we originally had the order. I'm sorry about that. The School of Social Welfare, I wanted to talk about a specific HRSA-supported effort that deals with integrated behavioral health workforce training that includes dealing with developing integrated teams to address opioid crisis using SBIRT, screening for brief interventions and referral to treatment. This is a project that was funded at Stony Brook University in 2017, and the background to this is something we've talked about quite a bit, that physical and behavioral health conditions, we know about the comorbidities, and in Suffolk County, the number of people that are uninsured is significant, and that we know that SUDs, substance use disorders, are one of the top 5 drivers of inpatient admission. So to address this gap that many people on Long Island do not receive preventative health care screenings or referral to behavioral health, that this project sort of targets that issue by utilizing a clinical training model, as I mentioned, SBIRT, to specifically deal with HRSA-designated medically underserved populations. It's an evidence-based public health approach towards integrating medical and behavioral care, and some of the outcomes using SBIRT, we can see here that we know from the Vermont data, for example, combined with some of our local data, is 1 in 5 individuals who receive an intervention, a brief intervention, were likely to be abstinent from drugs like marijuana, or 1 out of 2 we're able to reduce risky alcohol use, and is providing significant cost savings. So this is, am I doing on time? 1 minute. Okay, so obviously I wanted to, with the benefit of the time, talk about the ECHO model, specifically to telehealth. So this involves co-designed curricula, interprofessional training that MSW's graduate level, MSW second year advanced students, along with NP psychs, work in dyads in these community health centers, these designated areas in Suffolk County, to provide collaborative behavioral health and leverage these community linkages that we've learned that are helpful to, with regard to hub and spoke. I'm going to skip over this. And we have developed curricula that involve online modules to enhance collaborative practice-ready workforce, that these dyads are later able to do simulated practice. Our goal is to use standardized patients. Now they do these in real time after a warm handoff from the physician in these clinics. And so that we know that when we develop these integrated models using a brief intervention, that helps enhance the outcomes in clinical practice. So forgive me, I know I have the minute. I just wanted to say, I have to show you this slide because this was the purpose of this. The ECHO folk, University of New Mexico, how many of you have heard of ECHO platform? So University of New Mexico developed a model called ECHO, and it stands for, they remind us that people keep calling it ECHO but never spell out what it is, and people don't remember what it stands for. It's the Extension for Community Healthcare Outcomes developed at UNM. It actually started with HCV, dealing with hepatitis, and like Rick pointed out about telehealth and telehealth approaches, it's really, their mission really is to expand the workforce, not to create an expert-centric group of clinicians who specialize, let's say, in opiate overdose. It's more about enhancing the readiness of the workforce through providing a forum through a variety of technologies to enhance a workforce. They use basic video conferencing technology. Actually, Zoom is what they use at the moment, and healthcare workers in underserved regions can better deal with patients. So I think I have to be quiet now. But I have like 20 more slides. If you want to talk, I'm happy to talk, and so I will step aside.